Hi there, I'm Helen Leggett. I'm presenting to you today on the ASA Relative Value Guide, and this is a talk I gave for the Part 3 course at the end of last year. So it's presented to you by the Australian Society of Anaesthetists, and there's our web address. So the RVG, we're in our 22nd edition. It's exclusive to ASA members, and there's a hard copy that'll be mailed to you every year with all of the updated item numbers and fees and things in it. Alternatively, there's also an RVG app, which is dead convenient, to be honest. You can have it on your iPhone or your Android device. It's downloadable exclusively for ASA members, and it's a very handy way to carry around the RVG. So the content of this talk, first of all, just a little bit of history, then what is the RVG, what's the MBS, and how are you going to use the ASA RVG for your billing? So first of all, the Relative Value Guide. It's designed to accurately reflect anaesthesia-specific episodes of care, and it's a method to calculate the fees for that care. Prior to the implementation of the RVG, our fees were essentially tied to surgical procedure item numbers, and they were often just a percentage of the surgical fee. So the RVG concept was originally developed in California and brought to Australia by Brian Pollard in 1962. And it was refined to suit Australian practice and adopted by the ASA as policy in 1970. In 1971, the Federal Department of Health agreed to implement some of the RVG concept. But in 1971, the anaesthesia fees remained linked to the surgical procedure item numbers. And although they acknowledged anaesthesia time, the department calculated an average time for each given procedure, and that was what was allowed rather than the actual time taken. So with continued advocacy by the ASA over 30 years, in 1989, the AMA adopted the RVG into its list of medical services and fees, and this was followed quickly by insurers such as for workers' comp and third party, and then by the Department of Defence and Veterans Affairs. It wasn't until 1996 that the ASA was able to convince the Federal Department of Health to review the RVG for inclusion in the Medicare benefit schedule, and not until 2001, which is 30 years after the ASA started advocating for it, that the AMA-ASA RVG was adopted in its entirety into the Medicare benefit schedule. Look, it's a much fairer system of calculating anaesthesia fees. It's independent of surgeons' fees, and it does represent the actual work done by the anaesthetist. So the RVG is quite elegant in that it has an intrinsic ability to remain relevant despite changes in practice, new techniques, new procedures, whatever comes along. And how does it do that? So essentially there's a base procedure item number, and it's divided into body regions such as upper leg, head, whatever, and components of those body regions, so bone, skin, intraperitoneal. And those subgroups take into account complexity and physiological impact of the surgery and anaesthetic. So it matters not what the procedure is on a given area or component of that area. The basic item number and thus the unit value remains the same. But what does change are the items for time, for physical modifiers, for additional clinically relevant procedures which enhance patient care. And in short, added complexity changes the number of items that can be billed for. So therefore, a long and complex procedure on an unwell person is likely to have a higher fee than a shorter procedure on a well person, even if that procedure is the same and on the same body region. So a few terms that you're going to need to know. The MBS is the Medicare benefit schedule, and this is a listing of all medical services which are subsidised by the Australian federal government. It lists the schedule fee, which is a Medicare rebate which applies to that particular service. The MBS applies across all craft groups, and so there are specific items that are pertinent to each craft group. Each of the medical services listed is given a unique item number, and that's particular to that service, and so it identifies the service and the rebate that Medicare will pay for that service. Now, a few more things is the schedule fee. This is the full rebate amount that's associated with each of those item numbers. It's not a recommended fee. It's essentially what Medicare are willing to contribute as a rebate to the patient to the cost of a medical service. So the MBS schedule fee applies to private billing only, and it applies to Australian citizens and some other like visa holders and etc. It applies for doctor services in private sector, including in general practice, and it applies to hospital-based services for privately insured patients. The RVG unit value. So this concept is peculiar to anaesthetic billing. So each item number from the MBS is allocated a value of RVG units, which is the unit value of that item. So these units are essentially an increment of remuneration. So a unit has a dollar value. The unit is the multiplier by which you calculate your fee and by which Medicare and the funds calculate the patient's rebate amount. So there's one other thing is the AMA also has a schedule of fees. So this uses the same item numbers that fit with the RVG and the Medicare benefit schedule. It's a recommended unit value. And the aim is that it should be a fair reflection of the value of your service. It's indexed annually on the 1st of November, and they take into account CPI and average weekly earnings and I don't know what else to calculate and index that amount. Now that amount has been indexed since the inception of the RVG. Unfortunately, the Medicare benefits schedule has not been so regularly indexed. So what is an RVG unit value? So just a quote from the MBS schedule, the RVG basic unit allocation represents the complexity of the anaesthetic procedure relative to the anatomic site, physiological impact of the surgery. So the RVG is basically a method of itemising services to accurately reflect anaesthesia-specific care. So a unit value, it's a unit value-based model which is used to determine the fee for each item of service. Each service is allocated an item number, which is equal to a value or number of units. And the RVG item numbers mostly have an equivalent in the Medicare benefit schedule, although there are a few RVG items that do not. So when we say relative value, what's it relative to? So the relative value or the number of units that are allocated to each item is essentially a judgment of complexity. So when we talk about relative complexity, what we refer to is the anatomical site and the physiological impact of surgery. So for example, carotid surgery would be more complex and so attract a higher unit value or fee than, say, surgery on a big toe. The time, generally a longer procedure is an indicator of a more complex anaesthetic and a more complex procedure. The consultation and planning. So longer consults and more planning are generally associated with a more complex patient with respect to their medical history or perhaps with respect to the complexity of the surgery that they are going to undertake. The modifiers, so the modifying units, they're an indication of added complexity, and here we're talking about patient age, their status, whether it's an emergency or not. And there's also additional diagnostic and therapeutic procedures that are required for safe anaesthesia care and for enhanced patient outcome. And so extra units are allocated if there is, for example, a requirement for an arterial line or a CV line, as again, if a case which would require any of these things is generally associated with added complexity. So how do you fill in a billing card? There's a formula that Medicare wants you to follow. They want an order. They want your basic or procedure item first, then the time item, the consult item, any modifiers, and any extra therapeutic or diagnostic services. You'll notice on the front screen that there are a number of tabs, and then down the bottom, which I'm not sure if you can see or not, there are a number of icons. So the tabs are essentially the consultations, the modifiers, the anaesthesia, which is essentially the procedure item, other, which includes therapeutic and diagnostic services, includes other procedures that you might do in labs such as cardiac cath labs and neurology labs and things. So if you have any questions on billing, I would encourage you to apply to the ASA. Now, the ASA is there for you, to support you, to represent you and to educate you. And thank you very much for your time today.